let's go back for a second. Philosophically speaking, fundamentally, why is it okay that I accept certain risks? Why is it that I would be willing to take a medication when it's a known reality that it might cause an adverse drug event or an adverse drug reaction, a side effect? Why would I ever accept that risk? This is Generation Health. Every week we bring you the latest in news, cutting-edge research, and time-tested best practices, helping you live longer, better. To my right, Mr. Dante DiMatteo, PharmD, Certified Strength Conditioning Specialist. Good morning, sir.
Good morning.
And across from me, PharmD, board-certified clinical nutritionist, Mr. Joey DiMatteo. How are you, sir?
Very good, Tyler. How are you?
I'm fantastic. Behind mic number 4.
Yeah.
Josiah Schweinberg, engineer. How are you?
Doing well. Engineer extraordinaire.
Not so extraordinaire today.
Tired.
Original, at least.
That's it.
Engineer original.
His shirt says original. If you're only listening, his shirt says original.
That's right.
Is that the original shirt? The first one? This is a terrible joke.
That's the seminal shirt.
The preeminent. My name is Tyler Andrews. I am the host, for better or worse. We got a lot going on today, but we're going to talk about one big topic. What are we talking about, Dante?
We're going to talk about adverse drug events.
And that sounds exciting, and it is exciting. But first, let's find out what's happening behind the counter. Longtime listeners have no doubt heard us mention the gut-brain connection before. In short, it's the relatively new understanding that your gut health directly affects your brain. For example, we already know that at least 90% of the body's serotonin, a neurotransmitter involved in regulating mood and cognition, is produced in the gut. A new study, though, published in Biomedicine and Pharmacology, has continued to shed light on this critical interplay, but this time with melatonin. Melatonin is a hormone that is best known for helping us to regulate our circadian rhythm, our sleep-wake cycle. It's a key ingredient in our essential sleep for just that reason, but it also plays a key role in regulating our immune system. The study showed that a dysregulated gut, that is a gut without the proper balance of bacteria, can result in lowered production of melatonin, which then affects the body's ability to downregulate the immune response and inflammation, particularly in your brain. The broader implications are quite profound. Quoting from the study, quote, "These findings suggest that melatonin may have therapeutic potential in treating neurodegenerative diseases. The available melatonin levels appear to be significantly influenced by the intestinal environment. Therefore, under situations linked with dysbiosis, melatonin and the gut microbiota seem to coordinate and intensify one another, thus maintaining a healthy gut microbiome, reducing inflammation, optimizing melatonin levels, and supporting mitochondrial function may help prevent or slow the progression of multiple sclerosis, Parkinson's disease, and Alzheimer's disease." And I can hear our founder, Joe DiMatteo, right now saying, "I told you so." Back in 2014, Chick-Fil-A announced their goal of complete antibiotic-free chicken at all of its restaurants. And in 2019, they officially managed it. In their terms, quote, "No antibiotics ever." Well, that didn't last long. The company has announced that they are shifting away from no antibiotics ever and will now serve chicken with, quote, "No antibiotics important to human medicine," unquote. According to the company's website, the new standard, quote, "restricts the use of those antibiotics that are important to human medicine and commonly used to treat people, and allows use of animal antibiotics only if the animal and those around it were to become sick," unquote. So why does this matter? What's with that oddly specific wording? Well, the use of antibiotics in livestock is far and away the leading factor in the reduced effectiveness of antibiotics that we humans use. The more they are used, especially prophylactically for otherwise healthy animals, the less effective they become as bacteria mutates and adapts to survive. If antibiotics stop working, the results would be catastrophic. Chick-fil-A isn't the only major company to make the shift in recent years. Panera Bread recently made a similar shift for their pork and turkey products, and food giant Tyson reintroduced specific antibiotics to their chicken supply chain just last summer. So, unfortunately, the antibiotics are coming back with a vengeance, it seems.
So yeah, I know this article just came out, and I think it's worth a deeper dive, but it's not the time for that. I just did want to touch on it though. In terms of what this actually means, just understand that antibiotic resistance development in humans, this is more of a macro concern than a micro concern. So for example, even you taking an antibiotic, you could have side effects. It can cause issues with your gut flora, plus increased risk for side effects from the med itself. But overall, it's generally accepted that the concern is at more of a macro level when antibiotics are overused in a general population. So I just want to make a distinction. So you eating, Chick-Fil-A chicken sourced from an antibiotic-treated chicken doesn't so much make your body more resistant to antibiotics. The data has really shown that it's not really entering into the meat and entering into your bloodstream when you do that. So, this isn't good news. I'd rather it not be in animals. But again, I think it's critical to understand that if this is bothering you, it needs to be more at a big scale level, at a macro level. Maybe you don't want to support this company's meat for those reasons, et cetera, more than literally when you eat it, it's going to cause the issues that we're kind of assuming. Along with that, though, I do think that hormone use with the topic, maybe whenever we get into that, can be, I would say, a little more viewed at a micro level. That if you're eating meat that has been treated with hormones, especially milk, dairy, that these animals have been given exogenous hormones, I think that's where there's more of a micro individual concern. So I think that's something we'll explore more later on.
Thank you for pointing that out. I hope that was not unclear in the article. Yeah, it's not that you're eating antibiotics and that's a problem. It's that we're treating all 10 gajillion chickens and that's what they're saying. They're saying only sick animals are being treated, and only with antibiotics that aren't used in humans. But it's the general trend that is more concerning than anything else.
Yes, absolutely.
Absolutely. All right. Well, that out of the way, what are we talking about? Adverse drug events.
Mm-hmm. Mm-hmm.
Which sounds like just a great time.
It really does.
Okay.
Yeah.
What are we talking about?
To sort of get us started, it probably helps to talk about some of the terminology that's, seen in regulatory settings or in research or, even in your pharmacy. So in general, the overarching category that we're talking about is adverse drug events. That is the unfavorable or unintended response to a drug, whether or not causality is implied. These can be thought of basically, again, as the broadest classification or definition of things that include adverse drug reactions and medication errors, for example.
So side effects. We're talking about side effects.
Essentially. So again, what we'll get to, side effects or adverse drug reactions fall under that category of adverse drug events.
Okay.
So there are, it's not the only reason. You might be wondering, why do we even care about those classifications? It's just that, when reporting, when trying to classify these, when trying to understand what to do about them on a micro level, or as far as, the FDA potentially putting out a, safety warning or something for the public, it just helps understand what bucket these sort of fall in. And
Sure.
So to your point, mostly everybody knows these as side effects. Side effects, just to reiterate, fall under this overarching umbrella of adverse drug events.
Okay. So an adverse drug event is the big category. And then within that, there's adverse drug reactions and side effects and some other things as well. Mm-hmm. Is that right? Okay.
Yeah. And so ADRs, we can call them ADEs, but specifically ADRs, adverse drug reactions, these again can be thought of as your common side effects.
Okay.
So from the WHO, these are basically, from their definition, a response which is noxious and unintended, and which occurs at doses normally used in humans for prophylaxis, diagnosis, or therapy of disease, or for the modification of physiological function. So, fancy way of saying, we generally think that it's the drug that's leading to whatever is being experienced negatively.
A causal relationship. We think we're pretty sure it's a 1-to-1.
Definitely.
Okay. how do these occur? What is going on? Why is it that when I take a medicine for one thing, all of a sudden I'm having an issue with something else?
Mm-hmm. So the key point here is that even though it seems like what we're talking about is a very one-to-one relationship, there are certainly outside contributors that make these events or these reactions more or less likely to happen.
Okay.
So oftentimes it's related to the dosage of the medication that's used. And that doesn't necessarily mean the medication was overdosed. It just means that that individual had a heightened sensitivity, which is another contributor here. But yes, it's related to the dosage. It can be related to the individual patient sensitivity. It can be attributed to certain medication combinations. So those that are used together are more or less likely to, have an event or reaction manifest itself. Allergic reactions even fall into this category as well. And so those are a little more, I think, easily understandable or easily recognizable.
Right.
You take an antibiotic and you end up with hives or a rash, and very classic presentation of an allergic reaction. And then finally would be those that might be, which we won't really talk about. It's a little bit more of a loose end. These are the reactions that might be genetically predetermined.
Oh.
So there might be a way that an individual metabolizes certain genes that code for different metabolic pathways that might be different from one individual to another. And so I think over time, what you'll see with, pharmacogenomics and that sort of umbrella category is that dosing regimens, medication selection, all of those things, we might be able to make better decisions for people understanding what sort of genetic hand, based upon their genetic hand.
But
so that's
a future tech.
Sure. And it's one of those things that's always happening. It's always in the works. And there are certain things you can be tested for now.
Yeah.
But again, I didn't want to get lost on that. But it just shows you how many it's not just like this drug does this thing to every person and you have to watch out. It's just that you're not always playing on level ground.
Okay. So let me make sure you said dosage, the genetics, you said, sensitivity, patient sensitivity, and combinations, like weird combinations of drugs, and then what was the last one? Allergic reactions. Okay, those are the primary contributors to these adverse drug events, or
these are
reactions?
Technically reactions.
Okay,
yes.
All right. How serious do these get? My understanding is some of them are pretty serious.
Definitely. And they are quite wide ranging. And I think that the meat of this discussion, will shed further light on how wide ranging they can be, but they can be as, sort of innocuous as, it made my stomach hurt, or, I had this cough since I started taking this medication. And then all they had to do was switch you to another drug in a different class that does kind of the same thing. And then no harm, no foul, you move on from it. To all the way to now we can look at more or less the regulatory perspective of how serious these can be. And the FDA, what they consider serious outcomes are those that can lead to death, unfortunately, those that are life-threatening or pretty close to that point, hospitalizations, whether that's just a brief stint or something that requires long-term hospitalization, disability, congenital anomaly or birth defects, those that required intervention to basically prevent permanent impairment or damage. And then there's sort of this other serious category that is a catch-all for the things that don't fit those first 4 or 5. So,
okay.
And so that's how, those are listed right on the FDA website. And those are things that as a manufacturer or as a certain facility or certain healthcare center, when you see those sorts of things pop up, those are the ones they want you to obviously report very, efficient,
really
time,
pay attention
in a time
to.
sensitive way.
Okay. Yeah. All right. Is there anything else that we haven't talked about initially that we need to cover before we really dig into this for adverse drug events?
The last one quickly would just be medication errors.
Okay.
It kind of falls into its own category. These refer to preventable events that may cause inappropriate medication use or patient harm. They can occur kind of at any link of the chain, any stage of the medication use process. So this goes all the way from, prescribing and ordering of a medication to the communication of that order, storage and labeling, compounding at various stages, dispensing, distribution, administration, and then monitoring of the ultimate, medication dispensing process. And basically at least one of those steps had some sort of deviation from what normally should have occurred.
That makes sense. So then it's not that the medicine is at fault.
Mm-hmm.
It's that a human made a really bad mistake somewhere along this process.
Yeah, there are many things that could happen. So one way to think of it is just that, we talked about ADRs or adverse drug reactions. Those are the reactions that occur when the drug was given appropriately.
Right.
It was within reason of frequency, dose, administration, and something still occurred. This is an example where maybe something was overdosed or underdosed or given at the wrong time or too frequently, or one of the things that we mentioned,
right?
That would ultimately coin this a medication
Pills got
error.
Mixed up, or who knows what.
Exactly.
Okay.
So again, it's just, I think, important more or less to say that, hey, yeah, there's still this other thing that isn't necessarily specifically related to the drug itself.
It seems like with all of these things, like we've got all these different categories. It covers so many things. It seems like they're almost unavoidable, that something's going to happen somewhere along the line, whether it's your genetics are different or you're allergic to something or a human's going to screw something up. It seems like they're completely unavoidable. Are these preventable? Is there something we can do to reduce or eliminate these?
That,
because I don't want to deal with it.
Yeah.
I want to trust that the medicine I'm going to take is going to make me better instead of being afraid that it's going to hurt me.
Sure. That would be a conversation. That's a huge conversation in and of itself. But at the same time, I think that's why, podcasts like this exist.
Yeah.
That's why having a good open dialogue with your pharmacist or your, nurse practitioner, your doctor helps. I think that's why, we'll get to even how some of these events are reported. That's why it's important that as, sort of annoying or as tedious or as difficult as it is to report these events, it is important to try and report them as, as the healthcare professional or as the patient. There are ways that you can do that. Point being, and again, some of these points I think we will get to, but this feels like a natural point to at least mention it. It's that in the outpatient setting, which what we're generally talking about now, in the primary care setting. So you go to your pharmacy, you pick up your medication, you go home, you take it, you self-administer it. The adverse events, the adverse reactions that can occur from that, those are generally underreported. A lot of times people are afraid to mention those to their pharmacist. They're afraid to mention them to the doctor. And then, then you never hear about it because
right.
it hopefully wasn't life-threatening. But it just goes to show you still, even with all the technology and all the opportunity for communication for healthcare professional and patient, there's a huge gap for the things that have the potential to happen that might go unnoticed.
Is that because they're not a big deal? Most people just shrug them off, or, I guess that must be part of it, just because if it is, the reporting is readily available, you're saying, then that would be the reason I would assume people wouldn't report.
Yeah.
A lot of it too is whose role is it to do that? A patient has a side effect, and we're not talking about the major
right.
side. We're talking about things that are more than nausea, but not as critical as, something that would cause you to get admitted. Okay. So yeah, it's difficult to know, well, I told my pharmacist I had this issue. Well, my PCP knows. It's a lot of times you kind of just assume that somebody's going to tell and somebody's going to report it, but nobody does.
Yeah,
so,
exactly. And not to lose this thought, the key is there are certain things in place as a pharmacy. There are certain legal aspects that you have to, certain criteria that you have to meet from this kind of perspective here,
right,
in order to do business, basically, in order to work with the public. One of those being that every time you dispense a medication, it has to go out with basically a med guide that has the FDA's information readily available. And it even has a little blurb, contact your doctor, or contact the FDA, or call this toll-free number if you feel that something occurred in relation to this medication.
That's what's on that. I always just throw that in the trash.
Exactly. And so that was a huge step from a regulatory standpoint, from a day-to-day pharmacy standpoint. But the key is, even healthcare professionals, they're not legally required to, in a general sense, like in a retail pharmacy, you're not legally required to report a side effect every time, Jane Smith comes in and says that, oh, you know what, that gave me a rash, or that my stomach got upset, I had diarrhea, like whatever. You don't have a legal obligation to report those. And so to Joey's point, who's going to do it?
Yeah.
I'm not sure that the doctor's reporting those every time.
Right.
But what I can tell you is, based upon some of the statistics in the research we put together in preparing this, was that most of the event reporting comes from manufacturers. Why? It's because the patients are more likely to call the manufacturer and say, hey, your stupid drug.
Yeah.
I did X and Y. I think people love to pick up the phone and do that, or they can go on the manufacturer's portal and send them a little blurb and tell them what happened. And then ultimately, manufacturer has an obligation to report that to the FDA. But even that is a little messy.
Yeah.
So the one thing I found interesting there was that, so let's say you take generic fluoxetine,
Okay.
which was brand Prozac at one point. You take fluoxetine, somebody knows it as Prozac, so they reach out to the original brand manufacturer and they say, hey, this Prozac, this fluoxetine, I did X and Y, I had this issue. And so then it gets marked as like, Pfizer or whoever made it. It's as if it was their product that caused the problem, but really it was this other potential generic manufacturer that made it.
Wow.
Now, with lot numbers and NDCs and all that kind of stuff, that it doesn't necessarily end up that way, but it's just another small incident to show how even tedious and detail oriented this reporting process has to be. Because maybe it was the lot, maybe it was this NDC, maybe it was this manufacturer. The customer doesn't care, the patient doesn't care who it was. They just want to tell you that, hey, I had this issue and I think it was you, Prozac, that did it,
Right.
Yeah, that's a really good point too, because you wonder why sometimes, like, how didn't they know about this, or how didn't this come up? The reporting of it, like Dante said, is just so messy. So let's take that example. You're talking about, there were more extreme examples of contaminants and wrong doses in thyroid drugs, or, contaminants in like Valsart and the blood pressure meds. And what happens with that is it could just be one lot from one manufacturer and all the other ones are fine. It has nothing to do with the brand. So then you start piling in all this information about these events with Valsartan, but it has nothing to do with 80% of the Valsartan that's produced. And so how do you sift through all that? It's like with so many things and nowadays it's too much information if everybody's just kind of mind dumping on all these sites, and it's too little information if nobody's reporting things that are more pertinent. So sifting through all that is difficult. It just kind of shows you why it takes so long for these things to come out and to be dealt with.
So there are substantial issues with reporting and with underreporting just by nature of the way this works.
Yep.
Wow.
And I think back to the ultimate point that Dante brought up, it's when you're in the outpatient setting, the muddiness, the thankfully lack of severity with so many of these things allows it to fly under the radar versus, hey, I had this adverse drug event. It's this newish drug and I'm reporting it because I am in the hospital and you know what I mean? There's just a much more black or white way to convey that versus in the outpatient setting that so much gets lost in the sauce.
Okay. So how often is this actually happening? What are we talking about here? What are my risks of taking a medication and having something substantial happen?
So let's look at a snapshot of some numbers.
Okay.
In 2008, the FDA received more than 530,000 reports of suspected adverse drug events.
In 1 year?
In 1 year.
Okay.
And 33,000 of those were submitted directly to the FDA. But most of those, again, came from drug manufacturers. So it was probably, patient, consumer to manufacturer to the FDA.
Okay.
320,000 of that initial quantity was considered serious. And we mentioned what serious was kind of at the outset.
Yeah.
And then of that amount, at the top end of severity, nearly 50,000 resulted in deaths.
Wow.
So
Like that's like
a massive
9% or something like that. But
yeah, and some of that can be a little. I didn't pick apart all of those numbers.
right, and it's important to factor in there. That sounds like an enormous number, but that's how many millions and millions and millions of prescriptions were actually dispersed over the course of the year. It's not as enormous of a percentage as it seems initially.
Sure,
Yeah, there's a lot of
still
nuance. Yeah, there's a lot of nuance here, but I think it's just important just to show the scale of what we're talking about in the severity.
And the ones that are being reported are very serious.
Exactly.
Got it.
There was even another meta-analysis in 1994 estimated that more than 1 million Americans were hospitalized because of adverse drug events, which accounted for roughly 4.7% of all admissions. And then
4.7% of all admissions. Wow.
Yeah. So it's a large scale issue. And to your original question, there are a lot of things we can do about it. It's just something that is so multifactorial. I'm not so sure we'll ever bring that to zero, obviously, especially as new drugs are developed, new combinations, new hurdles arise. And then the last, I think, useful statistic here would be annual estimates of the proportion of outpatients with an adverse drug event range anywhere from 5 to 35%.
That's a broad range.
So a huge spread.
Yeah.
Again, just speaks to all of those issues with underreporting and outpatient,
But you're saying theoretically any adverse drug event could be something relatively innocuous like diarrhea or nausea or dry mouth or dizziness, something relatively minor all the way up to
Sure.
those big things. Okay. All right. So if that's me, if I'm taking a medication and something happens, how do I go about reporting that? Do I talk to my doctor?
You can. Yeah, that's never a bad idea.
Okay.
But again, as the patient, if you're listening to this and you do feel like I want somebody else to know what's going on, theoretically you can go directly to the FDA.
Okay.
Sounds scary. Sounds like how in the heck do I do that? This is via their MedWatch program. They have forms on their website, which are pretty easily accessible if you just Google them. Basically just, FDA reporting, basically.
Yeah.
It'll take you to this umbrella of things. And then also, if you've ever picked up a medication from a pharmacy, that legal requirement is that FDA information, that toll-free number will be there.
Oh, so it's on that printout.
Yeah.
That I recycled.
Exactly.
Got
That
it.
we
Okay.
recycle a lot of too, that somehow end up back with us, But the second way, if you feel so inclined, you can go directly to the manufacturer. And we've seen that. We've kind of started that process for people who, 85-year-old doesn't know how to use the internet super efficiently. Can you please send this in for me? This is upsetting me. I want somebody to know.
Yeah.
And your pharmacist, pharmacy tech can help fill some of this out. They can give you maybe the lot number, the NDC number. And so again, it does sound like a lot of work. In a lot of ways it is. It's just that on this global scale, if you want things to kind of be moving in the right direction for the next guy,
Right.
it's maybe not the end of the world to report some stuff.
Absolutely. Okay. Let's go back for a second. Philosophically speaking, fundamentally, why is it okay that I accept certain risks? Why is it that I would be willing to take a medication when it's a known reality that it might cause an adverse drug event or an adverse drug reaction, a side effect? Why would I ever accept that risk?
I think as we're starting off here, just want to make clear that as we're talking about being okay and accepting certain side effects, just there are certain populations, and this is not all inclusive, that should be a little more cautious, a little more vigilant. If you have a history of any anaphylactic reactions to anything, not just meds, be a little more vigilant when you're starting on a new med. If you're pregnant, or the key is might become pregnant, a little more vigilant. If you're breastfeeding, general intolerance of medications. And again, I always we're always going to kind of preach balance here, but if you have a general intolerance to medications or dose changes, you've had mild, obviously, past severe, any ADRs related to medications, be a little more vigilant. If you're on multiple meds, if you have multiple conditions, if you're elderly and disabled in any way, mentally or physically, those are all populations that should be a little more cautious when starting new meds, a little more aware, not hyper vigilant. A lot of things occur that have nothing to do with the new variable of the med that's been introduced. So it still requires care, but I just thought maybe to frame this and kind of just to kind of get that out of the way.
Okay. All right. So is it the leftover pizza I ate or the new medication?
Exactly.
Got it.
Yeah, I just started this yesterday and now all of this has happened. Well,
okay. But what is from a philosophical standpoint, why don't we just have drugs that don't have side effects? Why don't we just get rid of those?
In general, to any intervention like this, there's still a non-zero risk. And so, when a drug goes into development, when it's being tested in initial clinical trials, they're not trying to find the drug or the combination or the dose that ended up with zero side effects, zero issues, did everything they wanted it to do and didn't cause any little bit of, harm or controversy. It's just that they try to get to the point where those benefits outweigh some of those risks. And so again, at the very fundamental level, whether that's a supplement that's being studied, whether that's a drug that's being studied, very rare do you have something that's 10,000 points in this category and 0 in this category of any negatives. The other key is whenever like Joey said, when you're determining if a drug or a supplement is right for you, you're not necessarily weighing the same risks and benefits that the study was trying to seek. You're weighing your own personal characteristics. You're trying to weigh all of these different things that, you as the individual that a large study, when you see a huge cohort of 10,000 people, maybe didn't account for the certain characteristics, your certain makeup. And so it's about, it's not that you should ignore those risks, be very cognizant of them, but just know that there are going to be risks associated. And again, that's vitamin C, that's vitamin D, that's simvastatin, that's joint essentials, that's anything. There's a risk. There's certainly a risk benefit analysis that has to occur.
Makes sense.
Yeah, and related to the side effects themselves. For example, a new drug like Jardiance that helps with blood sugar, we know it works well. We also know it has some serious, what we would call, I don't know if this is the right term, moderate side effects, UTIs, vaginal yeast infections, things like that. So you say, well, look at this drug. There's these old drugs that work. Why Jardiance? It's this expensive drug. It causes all these things. Well, it doesn't cause hypoglycemia. So when you're looking at an old drug like a glipizide that also works, but that can hospitalize people, especially as you start getting into those higher risk categories. Yeah, and it is a big deal to get a UTI and a yeast infection. But when the FDA is trying to approve this drug, or your doctor's trying to decide what's best for you, this one's not going to cause hypoglycemia. So even within the side effect realm, the balance is always important to look at, not even just cure, quote unquote, or management of a disease versus side effect risk.
So it's about finding the balance, finding that trade-off where it's worth the risk that you're going to have some sort of issue. Okay. What are some other real world examples? Because I know, I need to know if I hear the drug that I'm taking or I'm prescribed, I want to know that there are some issues here potentially. What are some real world examples?
Yeah, I think this is beyond just listing them. It's hard to maybe categorize some of this stuff. So what we did, there was one paper from 2003 out of the New England Journal of Medicine, adverse drug events in ambulatory care. They just use really nice categories as far as the different severity and the different things you can do about these very specific events or case studies, more or less.
Okay.
And so they broke it into 3 categories. And I think that that's a good way to, unpack some of these. So what we'll do is we'll just read some of the mini case studies, more or less. And, if we have some color to provide, we'll do that. If not, on it, at face value, I think there's something to be gained from that.
What are the 3 categories?
3 categories. First one is serious and non-preventable. And I think the bulk of our examples will be in that category.
Okay.
The second is serious and preventable. And mind you, what the authors did, they looked through all of these cases, they looked through all of these events, and they determined based on numerous factors whether or not they were considered, like how, I'm sure somebody who's really listening is wondering, how can you determine if this was preventable? How can you determine if this was whatever? But it was a panel of individuals who tried to classify these. And I think they break out pretty nicely.
Okay.
Especially for this conversation.
Yeah.
Third one, I had to have trouble pronouncing this, especially under some anxiety. The Ameliorable side, serious events. And so Ameliorable is just basically that which can be made better. So those that there was something they could have done something about.
To reduce them somehow.
Mm-hmm.
Okay. All right. So those are the three categories. Give me some examples. You said the serious and non-preventable is the majority of what we're talking about here.
Yeah. And that is represented, in the data within the study. That's more what they saw in this cohort. Not saying that there always are more serious side effects. It's just in these examples, there were more.
Right.
And I think that they, of course, provide more useful discussion.
Yeah. And absolutely. And of course, I'm not as concerned with dry mouth as I am with, risk of death. That's a much more concerning side effect to me. Mm-hmm. So what are we talking about? Give me some examples.
First one, a middle-aged patient took a non-steroidal anti-inflammatory medication for knee pain.
Okay.
Very common issue, common thing we see every day. After 3 weeks of therapy, the patient was hospitalized for GI bleeding that required transfusion and electrocautery. The medication was discontinued.
Wow. That came out of left field.
Yeah.
That escalated quickly.
And I think with this whole category and its risk reward is just so critical. And I think we've said it a few times and it's like, wow, Joe, that's really groundbreaking stuff. But it has to color and frame all of this.
Yeah.
Because I still feel that so often we get into a tendency, this drug good, this drug bad, that kind of thing. So I think it's just critical to understand that, but odds are this was probably ibuprofen and naproxen. Not sure, but odds are that's what it was. And look what occurred, which is why you don't just say, oh, that's over the counter. Just take it like candy anytime you want, because at least you're not on some powerful pain pill. So again, no matter what it is in here, risk reward is the balance for all this. It's not about good or bad.
Okay, so somebody theoretically was taking a non-steroidal anti-inflammatory, something potentially over the counter, theoretically no big deal, but they ended up in the hospital with a horrible gut bleed.
Mm-hmm.
Wow. How common is that for folks?
I think it is something that happens more commonly than you would think. Ultimately what happens is the NSAIDs, part of their mechanism is platelet inhibition.
Uh-huh.
And so when that occurs, you end up with these bleeding lesions of the GI tract, basically.
Wow.
And that is a very crude explanation of how that occurs, but it does happen more commonly than you think. I think anybody in pharmacy school for your clinical rotation, pharmacists, you're only in the hospital for the most part on your basic rotations for like 5 weeks, 10 weeks at the maximum. And if you spend any time on any floors, you always hear of a GI bleed case, especially with somebody who, was taking an NSAID or it's suspected. So it's on the boards, it's everywhere. It's pertinent to the fact that everybody that comes into the pharmacy, we don't just like toss them a bottle of ibuprofen and send them on their way. We at least like to open that line of communication. What other meds are you taking? Are you on Eliquis? Whatever, not asking that directly, but just trying to get a very quick understanding and somebody who's just trying to get in and get out of the store.
Okay.
Yeah, because obviously if you're on other anticoagulants or other antiplatelets, the additive effect can be there. I think what's also critical in this part too is the start of the second sentence after 3 weeks of therapy.
Yeah.
So this, again, risk reward balance, what's going on here? Having a headache and once in a while taking an ibuprofen is not likely to cause a GI bleed. Having knee pain and once in a while after you work out a little bit, you take an ibuprofen. It's 3 weeks of therapy, assuming multiple times a day, that can cause it. So
okay. So it was the consistent long-term.
Yes.
Longer term. Got it. Mm-hmm. All right. What else? Is there more to that one that we need to know?
I think that's good. And I think the key is not to keep breaking off here. We're not going to cover every side effect. It's impossible. We're just going to do our best to highlight ones that, again, that either we see every day that are interesting in our little bubble, or what you might hear a parent, a grandparent, an uncle, a sibling theoretically encounter. Just some buzzwords, some things to be mindful of as you hopefully continue to have open dialogue with all of your care team, basically.
Makes sense.
So the second one, we can go through this one quickly for the sake of example. Nausea developed in an elderly patient who had recently started taking digoxin for congestive heart failure. At a subsequent office visit, the patient was found to have an elevated level of digoxin in the blood, which probably caused the symptoms. The reviewers concluded that the dose was appropriate for the patient's age and renal function. So this was just an example, Joey. I don't know if you have anything else to add, that seemingly did all the right things, but like stuff happens.
Yeah. This is one of those we aren't certainly sure necessarily.
Especially in an elderly patient, you've got something like renal function that can change over time. So initially this dose was correct and this dose was monitored and everything was fine. But for whatever reason, whatever else is going on, probably other conditions, probably other medications, there's a decline in renal function over time, which changes the framework here. So that's why it was interesting, because at first I'm like, well, maybe this one would be preventable, but no, the decline was occurring. She was being monitored. So it's just, again, one of those things just to, again, show you to be aware to stay on top of. Fortunately, this is a drug you could monitor and see a one-to-one connection.
So even over time, that's why sometimes you just have to redose medications just because things just change.
And reevaluate, yes.
Okay. All right.
And just a couple other, just like a quick one. An elderly patient taking a beta blocker had bradycardia. Beta blockers very commonly used, not just for blood pressure, but even post-MI for elevated heart rate, et cetera. So this is a relatively common side effect. This patient was hospitalized for 24 hours and the medication was discontinued. So, that could be something, especially whenever you're starting on, just to be aware. It's a medication that's purposely lowering your heart rate. And it should be doing that, but when it goes to 40s, you've got a problem. So if you're feeling dizzy, weak, extreme fatigue, anything out of the ordinary, again, hitting on the elderly patient here, but that's, I don't know how long this patient was on it. Odds are there's a decent chance it's relatively new initiation. There's a decent chance it's potentially a recent dose increase or something else is going on. Again, and so often, like I keep touching on, in patients, there's in elderly patients, you've got new conditions arising over time. Mm-hmm. You've got, organs like renal function, liver functioning declining over time, new meds added on board. All these things are mixing together to change what was once assumed to be fine to not be so fine.
Okay. So this was serious, non-preventable because there was no reason to expect this. It was doing its job. Theoretically, in this case, it was just doing its job way too well.
The effectiveness for this person, for whatever reason, was over the top.
Okay. So that's an interesting point there too, that sometimes it's not just that the medication does something completely out of left field that you don't expect. It's that, no, it did what it was supposed to do. It just did it better than what we expected it to.
Yes. And then to wrap up, the key thing was the medication was discontinued. Just to dovetail it with another one, an elderly patient who had been taking a beta blocker for 2 weeks had shortness of breath. So that goes with kind of blocking those beta signals can have effect in certain patients on the bronchioles. It has the opposite effect. So the patient was getting shortness of breath. The medication was discontinued. The symptom resolved. So not kind of just a one-to-one. It was started. The shortness of breath occurred. And it was 2 weeks. It wasn't like, a day or two. I was walking up the steps and felt a little different. There was a,
consistent
over time, but not debilitating either. This is not my throat is closing. I'll wait 2 weeks. This
don't do that.
This is, I'm noticing some shortness of breath. So this to me was non-preventable, in the sense of, shortness of breath is something that you don't want to occur, but the medication I'm sure had reason for being prescribed, very good reason. And then it was handled properly. It was discontinued and moving on to something else.
Okay. All right. Tell me about some serious and preventable side effects.
So there was an elderly patient with a documented allergy to a specific antibiotic. They received a prescription for the same antibiotic.
Whoops.
A whole body rash occurred and the patient was treated with epinephrine in the emergency room.
That sounds completely preventable to me. I understand why they would call it that. Okay. Mm-hmm. What else do we, so this is just human error, presumably.
So
We don't know who it is technically, but what was the source?
Which of the humans was its fault? We don't know. Okay.
That's right, because this is, again, we'll touch on communication being so key. I don't know. Maybe this patient was out of town. Maybe this patient's, they went to a new hospital system. Whatever the case may be, they didn't tell the physician who was treating them that they had this allergy. There's no other way besides being told or sadly observing it for a provider to know.
Sure.
So that this is somewhere, unfortunately, is a breakdown in communication and record keeping. It just depends on where that occurred.
Right.
Yeah. The one point that's not directly related to this case example that I think might be helpful. A lot of times it isn't just this black and white. Oh, they gave me this. I got the same antibiotic I knew I was allergic to. So occasionally there are some cross sensitivities of antibiotics that aren't the same.
Okay.
And they're not even in the same class technically. They're under like the same umbrella, but you look at the names and you may not think that, oh, this isn't an issue. I wasn't allergic to this, or I was allergic to this, but this looks completely different.
It's a different name, so it should be fine.
Sure. So the key there, leave that up to the clinician, your pharmacist, to try to work that out. But you as the consumer, you as the patient, is whenever you give your list of allergies to your new pharmacy or to your doctor, mention what occurred. A lot of times there are allergies that are misdocumented. This antibiotic that I took, it caused my stomach to be upset, or it did this, something that was not in the allergic related category, but
typical.
They just reported an adverse event to the pharmacy. Yes. And that's not a bad thing, but that needs to be in a separate place from the allergies to ensure that those allergies are taken serious. So basically explain what occurred so that when these things come up and maybe there's a chance for a cross-sensitivity reaction for a new antibiotic down the road, that at least your pharmacy, your provider has a bit of a backstory as to what occurred. So you don't need to be an expert in antimicrobial cross-sensitivity across classes.
Right.
You need to be an expert at explaining what happened, in a setting of intake or a setting of explaining your history.
From your perspective, what you experienced.
Yeah. And that's a great point, because so often we see the opposite ends of the spectrum on an allergy list. Like Dante said, you've got people that are kind of like, I know I'm not going to take penicillin, I'm fine. But they don't realize cross-sensitivity issues. Or you got the other end of the spectrum where there's this list of 30 things, and really, in a lot of cases, all of them are adverse events. Mm-hmm. So you've got this mix of communication overload because it's not proper. It's not in the proper category, but that can muddy the water so badly and allow clinical decisions to not be made, or to be made poorly because the information is wrong.
Okay. All right. And you're saying adverse events, not specifically
allergic reactions.
Like it's just my tummy felt upset, or I had a bad dream, or whatever, that it's giving more information than is necessarily applicable to the relevant situation, but that it causes cloudiness for all of the prescribers and everybody else, because they just see a long list and they don't have time to sit there and look through every single one and make sure that, oh no, that's legitimate.
Yes.
Yeah. And since we're here, these are things like shortness of breath, hives, rash, itchiness, things that are very hallmark to, I got stung by a bee and this is what it looked like. Those similar things can occur, in a setting of anaphylaxis to an antibiotic or whatever.
All right. That makes sense. Those are preventable. I get it. Any others in that category, or we get the idea there?
So the next one, just one more quickly here. A middle-aged patient who is already taking an HMG-CoA reductase inhibitor, so like a Lipitor statin. Okay. Received a prescription for an oral antifungal agent. This is a thing that can happen pretty commonly. Statins are very commonly used. Fungal infections occur, that this would come in. So this is, I'll finish the story here, but jaundice developed, requiring a visit to the emergency room. Use of these two medications together is contraindicated. So this is going into the preventable, largely because of a breakdown in communication here, because the antifungal needs to be used. And typically, I mean, azole antifungals do have this interaction. Azoles are kind of the standard. It's hard to get away from. But what could be done either at the pharmacy level, it could have been caught, or obviously at the prescriber level, this could have been caught. There are things to do to mitigate it, such as, and you would only do this, in conjunction with the provider, but stopping the statin for a period of time. There's a chance that if they would have just stopped that statin for a period of time, that this couldn't have occurred. Ongoing, if some patients are treated more long-term with these azole antifungals, permanent dose reduction. So I think it's just an important thing here to realize that even when there's an in-between, that drug interactions aren't always, this happens and it's bad or they can't be taken together. There are times where there's, as long as there's coordination, that there's, it can be ameliorated.
Yeah. Okay. And speaking of amelioration, what are the ameliorable side effects? Or ameliorable but serious side effects? What are we talking about there?
Yeah, the one that I think does a good job at explaining this would be the elderly patient taking a loop diuretic for congestive heart failure. They had increased urinary frequency for more than 3 months. The patient discussed the symptom with the physician, but no action was taken. The reviewers concluded that a dose reduction or an alternate day therapy might have ameliorated the symptom. So it goes right off right on the coattails of what Joey mentioned. There are systems in place that can bring these issues to the provider's attention without really even having to think about it, as there are, things in our software that theoretically bring these issues to our attention. But a lot of times, if communicated properly, if addressed, if noticed, everyone can be happy.
Yeah. A conversation can occur and things get squared away. Okay. Are there any others, or is that just a good example of that sort of thing?
No, I think we can maybe go through one or two more.
Sure.
A middle-aged patient taking a calcium channel blocker for hypertension had sexual dysfunction for more than 3 months.
Okay.
The patient discussed the symptom with his physician, who prescribed sildenafil or Viagra. The reviewers concluded that there are other antihypertensive agents that could have been attempted before sildenafil was prescribed. So this one provides a nice school case study. Overprescribing. Why did you pick this? This could have been solved. Very typical example.
So there were other steps that could have been done, other medications that could have been offered before adding an additional medication to fix the side effect of the first medication. Is that what you're saying?
Yeah, basically.
Yeah. And, this is one where if there were no side effects with the sildenafil, how bad is this? But it's still, why add additional meds on board when you don't have to, for various reasons.
And because eventually we could add another medication that we don't anticipate, and now we've got an actual serious side effect.
Correct. Exactly. It seems to be a common theme in some of these, but an elderly patient taking a beta blocker had sexual dysfunction for more than 3 months. The patient discussed the symptoms with her physician, but no action was taken. The reviewers concluded there are several alternative antihypertension agents that could have ameliorated the symptoms. This one is unfortunate. There are not only the change, but the sildenafil prescribing. So I think too, this could be a little time to at least touch on how many times does something like this occur, especially sexual dysfunction, that it's not brought up. That it's something that must, no matter what is going on, whether you deem it serious or you deem it not something, quite frankly, not something you even want to address or you're not comfortable with, how important it is, because there are things that can come down line from that in a lot of ways. So I think it's just critical to be upfront and honest about what's going on with you.
When something like that happens, it's because there's something neurological or biological that is changing, and whether or not that's a big deal to you, it's relevant potentially in the future for a host of other reasons. Absolutely.
And not to get too in the weeds here, but what can happen a lot of times is this patient doesn't talk about it, and what they start doing is skipping the med. So I think it's this med. I'm not sure. I'm a little embarrassed to talk to my doctor. I mentioned it. He kind of blew me off. And so I'm going to stop taking it. I'm going to start skipping my second dose. I notice if I don't take it as much, those kind of things occur. And then not only are you not treating, in this case, blood pressure or heart rate issues, now your doctor may be checking on you in 3 months and saying, I need to raise this dose.
Right.
Because it's not working. Your blood pressure's still high. We still have elevated heart rate. I need to bump up your meds. You're still maybe not telling them because you're embarrassed about both things now.
Man.
That is how a lot of these things in real life do kind of play out, no matter what the med is, that the side effect, if communication's not there, that the side effect kind of overtakes the patient's mind in the sense of the decisions that they make.
Okay. All right. This is going to be a long episode. We have got a lot here. My brain is full. What is the takeaway? I mean, it seems like communication with care providers, with your doctor, your pharmacist, making sure that you articulate the adverse drug reactions and events, the side effects, and giving everybody an opportunity to address those. That seems to be the punchline here. Am I hearing that correctly?
Ultimately, yeah. I mean, I think that, I've used the term in other podcasts, advocate for yourself. I just want to make clear what I mean by that. Mm-hmm. Advocating for yourself is not, walking into your doctor's office with a bunch of WebMD articles, and ready to like slam him with the information about why you don't want to go on this drug. First and foremost, what I mean by that term, not just related to this, but in general, is that you need to be honest and open. That's the primary message. Advocate for yourself in that you're having sexual side effects. Advocate for yourself that, I kind of didn't tell my doc this. I'm always missing that afternoon dose, but I don't want to tell on myself. Those kind of things. Just open up the lines of communication fully with your provider. That's the best way that they can treat you. And to balance that, when we hear it a lot in the pharmacy level. People will ask me questions, and it's not in a way where they want information or want help, although that's certainly there. There's like a defiance. They believe this, and they're asking you in this way so that they can kind of win the argument.
Right.
And I'm just being honest, I can't imagine what prescribers see in those initial and follow-up visits. That is just not where you want to be with your provider. Ultimately, that's only going to hurt you. Within balance, that's what podcasts like this are for. It is important for you to know things about the meds you're on. If you are able and willing to research some of the meds you're on and the conditions you're on, I do feel that's very important. That said, you're back to the first point. Your approach with your provider, or whenever you are calling that pharmacist for a question, is so critical, because when you present defiantly, remember at the end of the day, especially even with your doctor, you're still just dealing with a human being.
Yeah.
Had 3 of these tough conversations in a row, you're hammering them again. What are you going to get to the roots of the issue of these concerns? So I know that's more on the philosophical end, but at the end of the day, there's not enough examples we can go over that's necessarily going to hit what you may encounter, or what your elderly mother may encounter,
right,
as you move forward. So I think that is the most key aspect here. And hey, you say, hey, I've tried that. I really did try to talk to my doctor. They're not listening to me. If as long as you're comfortable that your approach has been genuine with respect for what they do know, but also still being very open about your concerns and about where you are with things. Changing doctors is not the end of the world, but make sure that you are accepting your role in that communication, that maybe you're not getting the answer you want, and maybe you wanted pulled off that drug at all costs. Hear why, hear the issues. Again, it could be something back to the Jardians thing, just off the top of my head. Well, this drug is costing my mother, $50 more a month than the other one. They got this yeast infection. I'm done with this drug. This drug is bad. Look what's happening there. I want $5 glipizide. Well, now you've just potentially put your family member at an increased risk for hypoglycemia. I'm not saying it's going to occur, but again, those are things that you just don't know, and that you're not going to pull up from a quick WebMD article or from a hot take Facebook post that says, Jardians, look at the yeast infections and these issues. Do you know what I mean? Yep. I just think that it's, again, not groundbreaking stuff. Talk to your doctor. I get it, but it's just I'm trying to frame this in a way that you can take no matter what individual things you agreed with or related to or potentially will see in your life, how you can make it kind of fit for you.
Remember that we're all on the same team. We're all working toward the same goal of being healthier, and that person is not your enemy.
Yes. Yeah. There's a lot of middle ground here. If you are having side effects with a medication, maybe the dose can be lowered. Maybe there are other classes. There's so many in-betweens that can occur that will only be arisen, A, if you're being honest about that sexual side effect, A, if you're being honest that you're only taking your SSRI 3 or 4 times a week.
Right.
Because again, back to the dose increase thing, I see it with one prescriber who does a lot of like custom thyroids in our area, that I'll see an increased dose, but then I'll look at this patient's history, and over the last 5 months, they've refilled it 2 or 3 times. Are they telling him that they're not taking it? Not really. That he's just looking at a blood level, time to go up a little bit. So again, just trying to put a real world kind of link here to what can occur if you're not being open, honest, and even in some cases telling on yourself.
Fair enough. My brain is full. I'm calling it. That is it for today. All of the products we mentioned, I think we talked about Sleep Essentials in the Behind the Counter segment. That is available on our website, askjoedimatteo.com, AskJoedimatteo.com. That site is where you can sign up for our newsletter, find past episodes of this show or the show that started all this, the Ask Joe DiMatteo show, all there on our website. If you have a question, we want to hear about those. We just did big question and answer episodes. We're going to need more questions for the next one. So email us questions@askjoedimatteo.com. You can find any show notes or articles that we reference down below in the comments section. And if you learned something from this episode, we want you to share it. Tell other people, drop a question in the comments on the video or anywhere you want, but share this show with friends and neighbors and relatives, folks who need this information. That is the best thing you can do to help us and to help them. Big thanks, as always, Josiah Schweinberg, our engineer, wearing the wonderful original chicken sandwich t-shirt there.
I might have to wear it next time we get together to record.
Fair enough. Michael Deppish, our editor, Joyce Gibb, our nurse practitioner who handles private consultations, Diane Silverman manages our product, Terry does scheduling, Cecilia does distribution. I can't read ahead. I have to stay on the line I'm on. That's Dante DiMatteo. That's Joey DiMatteo. I can't even point correctly.
I'm Tyler Andrews,
That's
and that's
right.
it for us.
Thank you. Bye, guys.